go to the next topic, which is another common clinical condition that we all encounter. It's COPD management in 2023 and update. I request Dr. Jairam Sir, the chairperson, former National Vice President of IMA, to take over the stage.
Today's subject of our discussion is COPD. The speaker is Dr. Sanjeev Nair, Additional Professor, Department of Pulmonary Medicine, GMC, Thrissur. COPD is a common thing which any specialist will come across in their practice. So the importance of it, say more than 12 million people are affected all over the world. I request Dr. Sanjeev Nair to enlighten the crowd regarding that.
Thank you, sir. Let me start by thanking Dr. Kidangur and his team for the invitation and for including COPD, which for us pulmonologists is a very important disease. Let me also start with the apology that I planned the presentation for more time. So probably I'll have to rush through a bit and I'll probably skip a bit and, stick to some of the concepts to stick to time. So I was hoping to cover a bit on the definition, a bit on the new concepts that have come of etiotypes, talk a bit on issues with the diagnosis of COPD, go on to the management, both pharmacological and non-pharmacological management, and while I'm doing that, also cover some of the practical issues that we face in our practice in India and Kerala. So the definition of COPD has been going round and round, and the world is circles come back to somewhere where we started with in 1998 or so. Talks of a heterogeneous lung condition, predominantly defined by the symptoms, and the symptoms have been described as dyspnea, cough, and sputum production. And there is, in this disease, involvement of airways and alveolar epithelium. And of course, it is persistent, progressive, not reversible. The main problem here is airway obstruction. All these things have to be there to make a definition of COPD. Why COPD is important? Because COPD is a major cause of death and suffering in India. Quite often when you meet politicians and bureaucrats and try to advocate for COPD, people don't realize that it is a second leading cause of death in India. Not many doctors also know that it's a second leading cause of death in India, and with this from WHO, you take global burden of disease, whatever statistics you take, COPD is the second leading cause of death in India and often not addressed. Generally, when we talk of COPD, people talk of smoking and COPD. Narendra sir just showed the NCD guidelines of India. The NCD guidelines of India sort of address COPD in just sort of one page, and the strategy that the government of India and our experts had was smoking cessation. So if you stop smoking, you got rid of COPD, so you don't really need to do more. But the point is, now you understand that there are various etiologies of COPD, starting from early lung development. So even from childhood, the pediatrician should be thinking of COPD. COPD generally is a disease of old people, but then, you have COPD D, which is from development, COPD, of pollution, COPD. So various, I will not go and read each of them, but the point is, there are various etiotypes of COPD, and world is going towards that. And with that, a lot of attention is coming all over the world, not just in India, on non-smoking COPD. So the Lancet Commission came out with a major report on non-smoking COPD. So COPD in people who do not smoke. And if you see those small circles at the bottom in that picture in that article, you can see that the second from right is the group of countries where India belongs. And you can see that only about a third of COPD in such countries, including in India, 1/3 of COPD in our country is due to smoking. The rest of the COPD is not related to smoking. So I am a big advocate of smoking cessation. Smoking cessation is very important for multiple diseases, not just for COPD. But then if you just go with that one strategy, you will tackle only about 1/3 of the COPD that could occur in the future. You will have to look for other things. Of course, air pollution in terms of outdoor air pollution and indoor air pollution is very important. But then with Brahmapuram and the Delhi fog and all, you might think that nothing can be done on that. But fortunately, you can see that there has been a lot of good in India. In terms of reducing indoor air pollution, our country has done very well. If you compare Pakistan and India, India has done particularly well in reducing indoor air pollution to almost half of what it had earlier. And Trivandrum has been extremely successful. We are also part of the study, and data from Trivandrum has come into that. And in Trivandrum, almost 90% of our households use safe fuel. Whichever way you define it. So there is scope for success even in that. Coming on to the diagnosis of COPD, how do we diagnose COPD? So COPD generally is diagnosed based on three things. One, you have to have the particular symptoms that we discussed earlier. So you have cough, dyspnea, and sputum production. You should have some risk factors. So we discussed some of the risk factors which occur in COPD. So you should have a risk factor. And when both of these are present, you have to do a spirometry. And in the spirometry, you have to demonstrate something called post-bronchodilator FEV1 by FVC less than 0.7. So for the diagnosis of COPD, you need to do a spirometry. Of course, spirometry is not that widely done. I'm sure nobody diagnoses a diabetes without doing a blood sugar measurement. Nobody diagnoses a hypertension without doing a sphygmomanometry. But when it comes to the diagnosis of COPD, people think that they can get away without the investigation and they can diagnose clinically. Of course, it's a sad reality that we face. What you need is you need a spirometry like this, in which you look at a particular value. One value is very important. Of course, there are a lot of issues with that also. That is the post-bronchodilator FEV1 by FVC, and it should be less than 70% or 0.7. Of course, the current guidelines have gone a bit further. So somebody with symptoms and risk factors, you have to do a spirometry, and obviously if the spirometry shows FEV1 by FVC, post-bronchodilator less than 0.7, it is COPD. But then in clinical practice, we do see a lot of patients who do not have this criteria, but you would still want to call them COPD. So for that, they looked at two things. One is something called pre-COPD, where the spirometry is normal. So in the morning, we've been discussing pre-hypertension. We'll be discussing pre-diabetes. So something like pre-COPD, where you can take preventive action and other things. And there's also something called PRISM, where the spirometry is reduced, but it is not the obstruction which is predominant. And these people probably will go into developing COPD. Having said that, the reality in India is often very different. So this study that I did in pulmonologists in Kerala, all over Kerala, we found that even among pulmonologists, 1/3 of pulmonologists diagnose COPD without a spirometry. So these are the specialists. And when you go down to the physician general practitioner level, study from Trivandrum that we did, you can see that only about 15% of doctors actually do a spirometry for diagnosing COPD. So it's the issue of spirometry not being available also. It's not widely available all over India, not just in Kerala. And people have been looking at alternatives. So Dr. Salvi's team in Pune came out with peak flow meter as a measurement. We have had public health programs in Kerala called Shwas and PAL in the past. And we have looked at mini spirometry as a thing. And in fact, in the places where we did this program in the primary health centers or the family health centers, the uptake of spirometry was very good. How good the quality was, we could not assess. But the point is it can be done even at a PSC level. And we were hoping that by doing it at primary health center level, we would force the specialists to actually take up the investigation. But COVID hit us hard, and we actually had to write a guideline to stop doing the test because this is aerosol generated and could spread COVID. So that was a setback for us. And these tests do work. They are very well correlating with the gold standard test, which is spirometry. Of course, the international guidelines are going forward and talking of doing DLCO and CT, but obviously when you can't do a spirometry in India, you're not going to do all these tests, so I'll not go into that. Moving on to the management, when you go to the treatment, there are three main aspects. One is the assessment of COPD, based on which you decide what drugs to give, the pharmacological management and non-pharmacological management. The most important event in a patient with COPD is considered to be the exacerbation of COPD. The white man, if you go to international conferences, they call it the lung attack, to put it in par with the heart attack. If somebody has a heart attack, they really take care of their health. But even if you have a lung attack, people don't care about it. They still go around thinking that they can get away with it. And each time exacerbation happens, the lung function is declining and the patient is at risk of mortality. Exacerbations have not very clearly been defined in the past. Current guidelines have gone more into the definitions of exacerbations and how you can define that properly. A shortage of time doesn't allow me to go into details of this, but a lot of agencies have come out with trying to define this condition better. Now coming on to the management of COPD, what exactly can you do for your patients? So basically what you're trying to do is to reduce symptoms, which is what we thought, which is important for patients, and reduce the risk of exacerbation, hospitalization and mortality and all. And for that, you have various targets you're trying to achieve. And that is what the whole management strategy is based on. But before I talk about the management of COPD, the most important thing to realize is that you have two conditions which are more or less similar and often mixed up, asthma and COPD. And both of them have to be differentiated. Often in field reality is that, we don't really try to differentiate between the two, and it gets mixed up. So our own study from Trivandrum showed that majority of our patients, more than 90% of patients, were not really told whether they had asthma or COPD. Just put together, and physicians often try to manage them together. Is it important? Yes, it is important. So if you have a patient with asthma or a patient with COPD, your patient with asthma is having an inadequate management if he or she has not received an inhaled corticosteroid. So if you're treating a patient who has asthma with just bronchodilators, you're putting that patient at higher risk of mortality. On the other hand, if it is your patient with COPD, you are supposed to give bronchodilators. And if you give steroids in patients who do not require steroids, inhaled steroids in a COPD, then you're putting them at higher risk of pneumonia and mortality. So the management is so different that it becomes very crucial to differentiate between these two diseases, which we often don't try to do. The principles of management are that you have to, as far as possible, treat the patient, or almost always treat the patient with inhaled drugs. The second thing is you have to choose the right inhaler and make the patient use the inhaler properly. The third thing is combination of drugs often work better than single drugs, so try to combine drugs. Long-acting drugs are better, like we had the discussion on hypertension in the morning. So the more these people have symptoms throughout the day, even at night, so a longer-acting drug works better in clinical scenario. And of course, inhaled corticosteroid only when you actually require it. I'll be using certain terms like this, SABA, LAMA, SAMA, and all that. I don't have time to describe each of these things because I'm running out of time, but those are the terminologies commonly used. The reality, again, in our state is that all said and done, still 42% of, this is Trivandrum, not even state, 42% of our patients are still started on oral drugs. Despite all of us knowing inhalers, it goes like that. 34% do get inhalers, but 27% of our COPD patients actually get started on a steroid-containing inhaler, which is not the ideal inhaler. The long-acting LAMA, which would be the ideal inhaler, was given only in 6% of our patients in Trivandrum. That's the sad reality. What would you ideally do? Ideally, you would classify your symptoms, your patients based on symptoms and exacerbations. So either the cutoff on the y-axis is either 1 hospitalization or 2 or more exacerbation going to the top. So such people are called the exacerbator phenotype, and they're called COPD-E. The bottom, if less exacerbation and less, no hospitalization at all, you classify them into A and B based on the quantum of symptoms, which is done by a MMRC or a CAT score. Based on that, you actually decide that, either any bronchodilator would work in your A group, which any inhaled bronchodilator. Your group B would require either a LABA or a LAMA, and group C is generally a combination of a LABA and LAMA, and a steroid added if you have either higher eosinophils in blood or certain other conditions. Patients started on treatment are monitored, and you look for 2 phenotypes, those who continue to have dyspnea. In those people, you try to step up the bronchodilators. The other group who have exacerbations, where you might add an inhaled steroid, or you might add other drugs like roflumilast or even a long-term azithromycin. When your patient is not responding, the first thing to look for is, are they using the inhalers regularly? Are they using it properly? And if they are, you try to change compounds of the kind of inhaler that you're giving to your patients. Inhalation, very important, and training your patient in terms of, the technique, training, making them demonstrate it in front of you, individually choosing the right inhaler for the right patient, and adherence is very important. Non-pharmacological treatment, equally important, something that we often forget. So reduction of risk factors we discussed in the morning, and there's an entire set of things that you could do as a part of non-pharmacological management. Stress on some of them. Vaccination, 5 vaccines are actually recommended. The influenza vaccine, the pneumococcal vaccine, the COVID vaccine, pertussis vaccine, and the zoster vaccine. Oxygen therapy, very important. One of the good things that COVID did for us, before COVID, we were running behind the administration and the political leadership to get oxygen and ventilators for our patient. Post-COVID, we have plenty of that. Most of our wards have enough oxygen and enough ventilators lying idle, so it's good for COPD patients right now. And you also, give NIV early, which has really improved the management of COPD patients. Of course, oxygen is a drug which actually has to be given in the right dose and the right time, and you can even discontinue. Often what happens is you start oxygen in a COPD patient, they go on. You can actually stop it in patients who don't require. Other very important thing is pulmonary rehabilitation. We've been trying very hard to get it done. We got even our previous health minister to come and do rehabilitation with the team, with all the doctors doing it, but still not taken up well. In that context, even general physical activity is good for your COPD. These are dyspneic people who refuse to move, and get them to walk. You go to Trivandrum Museum in the morning, you can see half the people walking there are people told by the cardiologist to walk because they had MI, but the COPD patients never come there to walk, so that is something that we can easily do for our patients. Until recently, I would tell my students when I teach COPD that all these things that do our management strategies and all do not make patients live longer. But of late, there is evidence coming up that many of the things that we do in terms of medications, in terms of oxygen, smoking cessation, in terms of so many other things, can make COPD patients live longer. So there is hope for COPD patients as well. Patient education, very important, but I will not go into details of that. I think it's important for all the diseases that we are discussing today. So running out of time, so I'll say that we have more understanding of the disease etiology today. We have newer concepts in diagnosis with thinking of pre-COPD and PRISM. Assessment is giving more importance to exacerbations. Inhaled bronchodilators should be preferred over inhaled steroid, which are used only in very specific situations. Inhaler training and selection is very important for your patients, and non-pharmacological management is equally, if not more important than pharmacological management. Thank you for the patient listening.
Thank you, Dr. Sanjeev Nair, for your fast and short coverage of the subject. Any questions?
Just one thing. Can you just elaborate on in a few seconds the benefit of breathing exercise? At what stage probably you can suggest breathing exercise? That is one. Number two, as an ENT surgeon, we see a lot of laryngopharyngeal reflex. And what I have seen is there is a coexistence of COPD in long-term basis. So what is your opinion regarding that?
Thank you, sir. Very good questions. I think your second question is easier to answer because COPD patients have a low placed diaphragm. The diaphragm is flattened, so you have reflux, which is very common. The moment they take a bit of food, they have reflux, and at night also they have. So they are not even able to take food, and they have severe malnutrition because of that. So GERD is considered one of the most important comorbidities, which I didn't cover in my presentation. There are so many comorbidities in COPD. Often COPD is considered as a systemic disease rather than a lung disease. So GERD is one of the most important one of them, and management of GERD as we do is extremely important in these patients. The first one, breathing exercise are very important, but when in terms of pulmonary rehabilitation, often to our surprise, the most important exercise is the leg exercise. So, lower limb strengthening is more important for diaphragmatic strengthening. People think of breathing exercises first. Having done lower limb strengthening, having done upper limb strengthening, the third one would be breathing exercises. In breathing exercises, various strategies have been tried, including yoga and many of the Eastern Asian strategies. They work quite good. The only thing is, only word of caution is that often we tell the patients to go and do yoga. And in yoga, if you could do pranayamas, many of you would have done pranayamas. The common ones which are taught are Anuloma, Viloma, and Kapalabhati. And Kapalabhati is well known to create pneumothorax in patients with COPD. So, the violent inspiration and expiration that happens as part of Kapalabhati can be harmful also. So often, practitioners of yoga and all would say that yoga is safe. It may not always be safe. Yes, so I showed a table which I just skipped through very fast. So that table has we have points in that. If I want to do it objectively, I would look at that table. I have points on either side. So 3 on each side would, if the 3 on the left side, I would say it's asthma. If 3 on the right side, I say it's COPD. If I have more than 3 on either side, both sides, then I would say it's asthma and COPD overlap. Yeah, FEV1 by FVC ratio earlier, we used to, FEV1, the ratio would be low in COPD, but if it is reversible, the FEV1, that is after a bronchodilator, if the FEV1 increases by 12% and 200 ml, I would say it's a reversible, airflow limitation, and that reversibility in the olden era used to be considered synonymous with asthma. But now we realize that maybe about 15 to 50% of COPD can also have a reversibility, and a well-controlled asthma may not have reversibility. So that criteria, even though it's very important, is not given that much of importance. Yes, sir.
Even some elderly people, it is after 47, some of them total asymptomatic period in between, last 4 months.
Yeah, I agree. So what you are trying to say is when we teach students, MBBS students, we would say that episodic disease is asthma and, continuous disease.
It will be normal. It's not possible.
Yeah, but the episodic nature in a very early COPD, that person may have exacerbations and that may be the only time he or she is symptomatic. And in asthma, you have these uncontrolled asthma who remain symptomatic all the time. In the ideal case scenario, I know that a patient who was say, symptomatic only 5 years back now had exacerbation is definitely likely to be asthma. Yes,
Thank
sneezing.
you.
Yeah.
Time is running short. They are reminding me.
Thank you. So I'll just answer that last question. So allergic rhinitis association is always with asthma, but when we have done studies from Delhi and from Kerala, my own PG got a prize for that. About 30% of COPD can also have allergic rhinitis. So, it's all very tricky. The differentiation often is difficult. Thank you so much. Sir. Thank you.
Thank you, sir. I request Dr. John Panikar, sir, to give a memento as a token of our appreciation to Dr. Sanjeev Nair.